Good morning and welcome to Global Healthcast, brought to you by Global Health Press. In this podcast series, once a week, we bring to you news and views about infectious diseases, vaccines, and vaccination. I am Joe Schmitt, and with me, as always, is Dr. Melvin Sanicas. Good morning to Switzerland. Good morning, Melvin.
Good morning, good afternoon, good evening to those who are watching us, and good afternoon to you, Professor Joe.
And this is our topics today. Cardiovascular disease and cancer are different but interconnected, and Melvin will explain that. In Norway, again, there is data now to show that COVID vaccination reduces the risks for long COVID substantially. As there is no treatment, very important information again. There is a first case of human B virus infection from Hong Kong. We speak about polio eradication, medical wearable devices, the role of artificial intelligence in future medicine, and fake vaccination, the possible impact of this criminal action. Melvin, you are to start. Cardiovascular disease and cancer. What's the interconnection?
Yes, so this is a very interesting review from authors from the University of Pennsylvania. Basically, they summarize the current epidemiological data for each of the modifiable risk factors shared by the two diseases, including hypertension, hyperlipidemia, diabetes, obesity, smoking, and many others. And basically, they are saying that cardiovascular diseases and cancer have a bidirectional relationship with shared mechanisms and risk factors that really predispose individuals to both disease states. And the shared modifiable risk factors, including hypertension, diabetes, obesity, smoking, and social determinants of health, they're actually something that we can do something about, right? All of these risk factors. They also mentioned that patients with cancer are at increased risk of multiple cardiovascular disease subtypes, as well as death from CVD, owing at least in part to the development of shared modifiable risk factors. So it's like one is making the other more serious or exacerbating the condition. And they also gave some hypotheses on what are these potential shared mechanisms. So including chronic inflammation, oxidative stress, metabolic dysregulation, microbial dysbiosis, hormonal effects, and cell senescence. So these are things that we know from each of these two diseases, but I personally have not really connected them that they could be related. So I think this is a very interesting review.
Yeah, I agree. And furthermore, looking at this, I see chronic systemic inflammation. And that reminds me that chronic inflammation and chronic infections do cause cancer, like hepatitis B causes liver cancer. It's a chronic infection. There are these gallbladder cancers associated with parasitic infections. There are all types of infectious diseases with chronic inflammation that result in cancer. So maybe the authors should also look at the interconnection with infections. What do you think?
Yes, definitely. I mean, more and more people are now looking at the relationship between cancer and infectious diseases because of the pathogens that you've mentioned, right? Hepatitis B, and also other pathogens like HPV, Epstein-Barr virus, and all these other viruses that we know have chronic states. And because of their chronicity and chronic inflammation or whatever they're causing in the body, potentially they can induce cells to become cancers in the future. So
Yeah.
yes,
Yeah, thanks for sharing. And this is a very interesting piece. I've never looked at it this way. Your next topic is COVID vaccination and long COVID.
yes. So this is a new correspondence on the Lancet Respiratory Medicine. I think we have mentioned this in at the Global Healthcast many times that vaccination helps with long COVID, but I think it's still important to repeat again and again. This really showed that COVID-19 vaccination reduced the risk of long COVID by at least 40% in the entire population of Norway, which is around 5.4 million. And it also reduced the risk of cardiovascular and thrombotic events. And it's interesting because they actually look at this in 4 different cohorts, right? So cohorts including cohort 1, age 75 and above, cohort 2, 65 and older, cohort 3, aged 18 years old and older with underlying conditions, and cohort 4, aged 18 and older, and vaccinated people in different cohorts. And so it really looks at how useful COVID vaccination is in all these different cohorts, in terms of protecting against long COVID and also cardiovascular and thrombotic events.
Very interesting piece, specifically as there yet is no therapy. So if you have long COVID, there is nothing much you can do. There are all these various efforts, but since we don't understand the pathogenesis, and people do not yet agree on the pathogenesis or the different types of pathogenesis of long COVID, get the vaccine now, right? Get vaccinated again in autumn for the next season to come, and think about it now, to make sure that you don't come down with long COVID. Do what you can. That is the message here.
Exactly.
Melvin, this is an interesting story, and maybe you explain, or you tell us the story first of all.
Yes, so Hong Kong's Center for Health Protection announced last week that it recorded the first human case of B virus, also known as the herpesimiae virus. Um, it's serious but very rare. It's a viral infection diagnosed in a 37-year-old man who had contact with wild monkeys and was wounded by monkeys during a visit to the Kam Shan County Park in late February this year. So this B virus is a rare but potentially serious viral infection that can affect humans who come in contact with macaque monkeys. To prevent B virus infection, it's important to avoid contact with the wild monkeys and refrain from feeding or touching them. And in case of exposure, immediate medical attention is necessary. The CDC, US CDC, states that the B virus was first identified in 1932, so a very long time ago, and that only 50 people so far have been documented to have contacted this infection. And of the 50 cases recorded, 21 patients have died, so it has a high fatality rate. And the CDC also said that these cases were infected after they were bitten or scratched by a macaque monkey, or when tissue or fluids from a monkey got into their broken skin, such as by needle stick or cut. So I think it's important to note that even though this is very rare, it's good to avoid these wild monkeys, right? That's the message here.
Yeah, don't touch them, right? I remember visiting Batam Island, close to Singapore, and they were on the street of our resort all the time. Actually, they even came through our windows and they
Mhm.
stole the potato chips.
Yep.
And I guess it's a good idea to still not touch them or fight
Yep.
with them, right? Gee, that is really interesting. And maybe coming back to a pandemic situation, wild animals have funny viruses, may carry funny viruses, and jumping over to humans, they may cause severe disease with a high case fatality rate. And I guess this virus probably won't be transmissible from human to human via the respiratory route, only by blood. So you need to protect the patient even from yourself, right? You need to protect you. The medical staff really is in danger for when taking care of the patient. Yeah,
Mhm.
very interesting. Thank you very much, Melvin. Another great story. Poor man. I really feel bad for him. I'm covering the latest WHO review meeting of the polio situation on the globe. And the good news is only in Afghanistan/Pakistan, there are wild polio viruses circulating. And actually, you see that here on the map, it's wild polio virus 1 only, 2 and 3 are gone. The bad news is that what you see in this orange color is the circulating vaccine-derived poliovirus 1. So this is the poliovirus that comes from vaccination campaigns and that is spread from vaccinees to other subjects, and that occasionally may cause paralysis. And that's you see here in Madagascar, and you see it in Central Africa. And finally, there is circulating vaccine-derived poliovirus 2 that you see all over Central Africa and here on the Arabic Peninsula in the south. So overall, the good news is wild polio virus is close to elimination, but we still have a problem. We need to increase vaccine uptake. Maybe, Melvin, what does the map tell you?
Well, this looks like there are really more cases because, as we know, one case identified with polio means that there are other 100 or maybe even 1,000 cases out there not diagnosed. Or so I think this is really just the tip of the iceberg, right?
Yeah, so the 7 and 8 cases relate to 100 to 1,000 more subjects who spread the virus. They are infected, but they don't develop paralysis, but they're out there and nobody knows about them and nobody knows who they are. So that is the data look low, right? 7 cases is not much and 8 cases is not much, but in the end, there are probably some 1,000 people who spread the virus, and we don't know who that is, right? So that is the bad news here. Yeah. Yeah, nothing. This is just a situation for you as a traveler. Be aware, you still should have your polio vaccines until there is the final day of polio eradication. I hope to be alive when that happens, and I hope it is soon. Yeah, but Melvin, any other view on that one, or can we go ahead?
You know, the first time I heard about these polio eradication effort, there were 4 countries during that time who had still polio as a public health problem in their countries, right? So there's Nigeria, India, Pakistan, and Afghanistan. And so at least there's some improvement, right?
Yeah, there is improvement. That is the real good news. Yeah, yeah. All right, let's go on to the next topic, which is wearable digital health technologies. And what you see here, what we can do today is you control your diabetes with a wearable. You look for epilepsy and for seizures that can be detected by your wearables, for depression, and for your cardiac situation. That is the good news, and we're all using these. Many of us are using these wearables, particularly these electronic watches. There are some unsolved problems like who owns the data? Can patients use it? I mean, it's not always that simple. What does the result mean if you get a warning message? There are some other challenges, including reimbursement and return on investment on these devices. So there are advantages and there are some issues to be addressed, but this is not really all of what is called artificial intelligence in medicine. And here is what I want to summarize on artificial intelligence with a specific view on infectious diseases. The medical procedures will be the same what we did over centuries. We will take the medical history, examine the patient, take blood or specimen for the laboratory, do some imaging, chest x-ray, whatever, come up with a differential diagnosis, have a therapeutic and preventive options, and the patient can decide what he wants. But the medical history taking can now be on file with structured questions. You don't have to start all over again with all your past medical history because that's already in the system. The system knows where you live, it knows your ethnicity, it knows everything about you up to date, and you just enter the additional news that you have. So that will be quicker and it will be more systematic. Then the physical examination may be accomplished by machines, by wearables, by whatever, right? At least to a large part. And then the artificial intelligence calculates the differential diagnosis based on pretest probabilities. I'm in Germany. If I have a fever, it will not be dengue. So dengue will not appear in the pretest probability. But if I traveled to Singapore and I return, then that would be on the top hit list of the differential diagnosis. So AI calculates the pretest probabilities for different diseases and then comes up with further testing and imaging suggestions. Finally, there will be hit list of differential diagnosis by artificial intelligence, giving probabilities like 10% that is dengue, 50% it is malaria, 10% of, look, you come up with different probabilities. Then the real value of AI will be to suggest next steps. It will come up with a patient plan for additional tests for therapy and prevention, including cost aspects, availability of the test, like all MRI slots are not available until next day, Friday, and a chest X-ray may be needed now, or maybe something we can get a quick result or confirm the diagnosis now. So that would be all in there. You would have your pretest probability, PTP, the time and scheduling. So that is really something that would be the big advantage by AI. Finally, this may include resource planning and cost analysis in the decision process. And this is a little bit dangerous, depending on how you program your AI, depending on the algorithms. It may be to your advantage or to your disadvantage. So it may be necessary that humans will always verify and approve the final plan, and that the patient has the last word to decide on what he or she wants, and not AI. I hope this is an understandable summary, Melvin, the way I see that. Maybe you have some additional aspects or views here.
Yeah, so I think we can never escape AI now. It's being discussed by everyone everywhere. It's really important to remember that I think although AI has really excellent potential for improving disease diagnosis, uh, potential for treatment selection, and also even clinical laboratory testing, right? It can help us with those algorithms. Like what you said, the AI is only as good as how you train it. And at the moment, I think it's also important to note that all these different studies done in AIs, they have been done usually in the US or I think in Europe. And maybe what is good for the population in US and Europe may not be good for other populations in Asia and Africa. So I think we have to remember that these algorithms should be retrained and verified in wherever you want to use them, and just not get something from one country and use it in another country without really verifying whether it's applicable, or it's also able to diagnose similarly, right?
Yeah, very good point. Excellent point. It has to be regionalized.
Mhm.
And it may be, it even has to be individualized. And that should all go into one medical history taking, right? The system has to know who you are, where you live, and what your preferences are.
Mhm.
Very good. And finally, I have a last story here, fake vaccinations. It is from the German Frankfurter Allgemeine Sonntagszeitung, one of our best newspapers in the country. And they reported, and they found a nice story, that it is easy but criminal to fake vaccination card. Actually, for 660 euros, you can get the full confirmation of being vaccinated for your young child, with lot stickers, even with a physician seal attached. And you should use the physician seal because otherwise, people may say, "Oh, I'm not sure if this is real," but if you have it all, it is perfect. It cannot easily be seen that this is a fake vaccination. So this is really dangerous, and here are the points why it is dangerous. Number one, it is dangerous for your own child because measles is dangerous, and infectious diseases may be dangerous. That's why vaccination is recommended. But also other children in daycare who are immunosuppressed, who have a cardiac transplant, or who have corticosteroids for whatever reason, they are in danger. HIV positive subjects, pregnant women, cancer patients, they may all be negatively infected by the non-vaccinated child to spread measles. Then wrong public health decisions may result from presumed high vaccine uptake, And you think you're very well on track, and we very good with our measles uptake, but we are not. And finally, you would wrongly assign vaccine failures. And in fact, a child coming down with measles, with documented measles vaccination, is not a vaccine failure, but with a fake vaccination card, it is a failure to vaccinate. And that is no longer distinguished. And again, I have as an example here shown that complications of measles are death. The case fatality rate is at least 1 per 1,000 children. SSPE, subacute sclerosing panencephalitis, kills children within 7 years after disease started. And particularly this affects those who get measles in the first year of life. And then there are other complications like pneumonia, otitis media, which means a lot of health care needed for a child because of a missed vaccination opportunity. So again, this is criminal, but we just wanted to highlight that it is out there, and people, particularly physician colleagues, should be aware of vaccine failures who are in fact failures to vaccinate. Melvin, what's your view here? Any comments?
Just a question, Professor. So what happened to these parents who were using this fake vaccination cards? Is there some form of punishment?
Look, I'm not a lawyer. I think this is criminal action and you may be punished, but I have not heard of any case where that happened.
Okay.
Number one, if you fake it and they catch you with having a fake vaccination card, you may be punished for I don't know what. The issue is more, you fake the vaccination card, your child gets access to the kindergarten, comes down with measles, and another child dies. That probably would go to a charge for you being the culprit in a death case. You are responsible for the death of a child. So that would be that may be the extreme form. But in the end, not being a lawyer, I cannot really tell you, but it is definite. Look, it is faking a document, right? Faking a legal document. This is criminal, but I don't know the charges or the punishments you may get. Okay, I think, Melvin, with this, we've come to an end for today. And Melvin showed us the interconnections between cardiovascular disease and cancer. We showed that while there is no treatment for long COVID, there is prevention by vaccination. We spoke about the first human B virus case in Hong Kong. Polio eradication, it is still with us, but the wild polio circulation has largely evaded. We spoke about medical wearables, AI in future medicine, and we looked at fake vaccination cards having a possible impact for public health. Melvin, thank you very much for your input and for your cases and for your studies today. Thank you to the audience for listening, and I wish you a very nice week. Goodbye to you and goodbye to everybody.
Thank you, everyone. Stay safe.